Hi there, welcome to our pharmacy revision series by CBH Education. Today we're going to be talking about opioids. So we're going to be talking about the mechanism of action of opioids, the key aspects you need to know, the pain ladder, conversion of oral morph to standard release morphine using a case study, a polypharmacy review or structured medication review using a case study converting tramadol to morphine, and advice for withdrawing patients. Okay, so the mechanism of action, there are three classes of opioid receptor, the mu, the kappa, and the delta. Side effects include arrhythmia, dizziness, nausea, respiratory depression, and raised intracranial pressure. Indications, it's used for chronic pain. Monitoring is long-term LFTs and side effects. Now, one of the things to help you with your revision and aspects you may come across in clinical practice is the behavior of ordering, the behavior of issuing prescriptions, and also the behavior of overuse as well. Now, it's very important that obviously you review that patients are having their medications within a certain time frame and they're not over ordering, because then this can increase the risk of side effects, and then that needs to be explained and monitored. Increasing the dose of medication, it's important that they are reviewed and once you've increased the dose within a specified time frame to ensure that there's no side effects and that they are on the right treatment regime as well, and that the medication is working for them and reducing the possibilities of interactions as well. Are the patients using two or more opioids? If they are, it may be due to historical prescribing, and then from this point here, you then may need to put the patient towards counselling them on looking at other alternatives. And you do have alternatives now which are non-pharmacological therapy where they can be referred to as well, and patients can be referred to social prescribing. Cancer care is different and advice needs to be taken from the specialist. Opioids and addiction. Because of the risks associated with opioids, and you've seen with the opioid epidemic in both the UK and USA, one of the things now is a treatment plan. So before initiating the opioid, you explain the risks about initiating, where the dose, how it's going to be increased, the maximum dose, and the withdrawal strategy from the patient as well. You'll talk about the risk of respiratory depression to them, and then obviously the risk of serotonin syndrome when it's co-prescribed with antidepressants or if the patient's using illegal drugs as well. Okay, the opioid pain ladder, codeine, tramadol. Tramadol is prescribed as short courses, but rarely now used long-term due to the increased risk of side effects and the withdrawal effects as well. And also in the elderly as well, it's not recommended for use. Morphine, after morphine, you can go down the oxycodone or buprenorphine route as well. And then when it comes to fentanyl, it's very important that your patients understand the long-term risk of fentanyl as well, because fentanyl has been attributed to a lot of opioid-related deaths and opioid toxicity. So here, fentanyl, most practices now will be instructed by the pain specialist to start, or the pain specialist will start it, or some formularies now are saying that fentanyl has to be started in a specialist setting as well. And then obviously after fentanyl, it goes to the pain specialist where the patient is reviewed. You then have drugs like tapentadolol, but that is undertaken by very in a specialist setting. Each patient will have a different tolerance to opioids. So here, it's key to undertake a drug history, what they have had before, to ensure that you are looking at the risk of interactions, you are looking at the risks of safety, safe prescribing, and that the patient is having reduced side effects as well from the medications and preventing adverse drug reactions. Okay, a case study. To put into context, this case study came about because the patient was transferring from one GP practice to another GP practice, and the GP practice that I was working at, patients were only given Oromorph 50 milligram every month. This patient was receiving in excess of 600 milligram of morphine or Oromorph every few weeks, or morphine sulfate. So the patient JC was overusing the Oromorph every month, and during a recent medication review, you want to provide a more appropriate formulation of morphine. They have stated they're waiting for a hip replacement and are using 30 ml 3 times per day. And the patients on the following medication: empagliflozin, metformin, alogliptin, codeine, paracetamol, naproxen, lansoprazole, Oromorph, and it's supposed to be 10 mg every 4 hours. They've got no allergy, biochemistry, no abnormalities, and the patient was weaning off the codeine as it gives them headaches. What would you convert the patient to, and what would you recommend for the GP to prescribe? So in this case study, the patient admittedly saying, look, I'm using 30 mils 3 times per day because it's helping me with my symptoms, it's helping me with my pain. I'm not having any issues around this as well. But from a safe prescribing perspective, it's really important that to counsel that morphine sulfate is actually used for breakthrough pain. So how did things work for this patient? So the first strategy is to take the Oromorph into account. work out the daily dose. So the total daily dose was 180 mg, 60 ml to dose, times that by 3, and then obviously we then convert it to a modified release formulation. So one of the concerns was the patient having the Oromorph because of swallowing difficulties or any issues in taking capsules or tablets? The answer was no here. So Zoamorph was first line, and they were prescribed 60 milligram BD. But in that as well, they were then, before it was initiated for them, they were given a treatment plan of how long they would have the 60 milligram for after their discharge from the hip replacement, and then how they were going to be weaned off the morphine as well. The patient was given the 60 milligram. Once they were discharged from hospital, a medication review was conducted, and then they were then weaned off very, very slowly over a period of 4 months. And one of the things was to counsel them about this, about their treatment plan, because as mentioned in the aspects of clinical revision, it's really, really important that you've got a treatment plan set in place so you're doing safe and effective prescribing. Next case study was patient JX has chronic back pain. The context of this case study was that the patient was on long-term diazepam, and at the practice I worked at, patients were weaned off of it because they were using benzodiazepines in a licensed manner for the shortest amount of time possible. So they were re-requesting diazepam. This was rejected, triggered a medication review. The patient wanted a solution to the chronic pain as they were on the waiting list for an operation. Which was in 16 weeks. You were going to conduct a polypharmacy review, a structured medication review, potential drug interactions, complaints. Other complaints were breathlessness with your inhaler regime. Now, obviously, if you're an independent prescribing pharmacist or you're a pharmacist in GP surgery and undertaking medication reviews, you've got to feel that you're competent in understanding managing different conditions as well, understanding medications, understanding drug interactions, and where you can make changes appropriate and inform the GP of this as well. So the patient was taking obviously Foster, Spiriva, aspirin, bisoprolol, omeprazole, ramipril, GTN spray, sertraline, gabapentin, tramadol, modified release, codeine, amitriptyline, medical conditions with COPD, NSTEMI, chronic back pain, diabetes, hypertension, and then previous medications that they had tried was becodamol, paracetamol, etocoxib, celecoxib, diazepam, and carbamazepine modified release. So, in context, how were things organized for this patient? So the first thing was COPD, they were changed over to triple therapy, Trimbo, because obviously upon counselling use of Foster and Spiriva, they weren't using it regularly as they found compliance difficult, and their symptoms improved when they were put onto the Trimbo. Anticholinergic burden score is a very important thing. So patients taking things like antidepressants or drugs which cross the blood-brain barrier, that should trigger the ACB score. And it's good to put this into your structured medication reviews because the higher the score, the higher risk of falls and confusion. So the medications that are attributed to the ACB score are codeine, sertraline, amitriptyline, and tramadol. The risk of serotonin syndrome was explained to them as well. Now, next was the pain regime. So the codeine they were using sparingly stopped straight away, but this leaves you with the tramadol. So they were using tramadol modified release. So basically, 1 milligram of morphine is equivalent to 10 milligrams of tramadol. They were using 200 milligrams of tramadol a day, which is equivalent to 10 milligram, 20 milligram of morphine. So they were prescribed Zoamorph modified release, 10 milligram BD. A treatment plan was put in place for them as well. Because one of the things is the patient's taking amitriptyline, the patient's taking gabapentin, and also the patient's taking sertraline as well. Now, these are potential for drug interactions. So what was actually done with this patient? So this patient was then, once they had had their operation, their pain was reviewed again by the pain specialist, and recommendations were made to reduce the gabapentin and the amitriptyline for the patient. And a treatment plan was put in place with their morphine as well. So once they had the operation, they were then obviously on the Zoamorph for a few months, and then this was weaned off very slowly. So then they were changed to MST Continus 5 milligram once a day, and then it was stopped. And then they were reviewed for withdrawal symptoms as well. Now, one of the key things with medication reviews is patients are on so many medications, it's becoming a lot more complex to deal with certain issues. So you've got to look at tackling each issue and how you're going to do it as well. And you can talk to your PCN pharmacist, community pharmacy, and everything is now integrated. So even when you're working in GP practice or community pharmacy, it's very, very important that obviously you're looking at how you're going to support the patient with the reductions as well and communicating that with the patient as well. Withdrawing opioids. So whenever you withdraw an opioid, they carry the risk of withdrawal symptoms. So everything should be done in a stepwise approach. There's no specific time frame on this as well, and you've got to go in the smallest increment you can and do everything in a stepwise approach. You've got to be reviewing your patients regularly as well, weekly, or where they need support further. And once you have weaned them off as well, it's better to review them as well to see if they've got no withdrawal effects either. Thank you very much for listening to this presentation by CBH Education on opioids. For further presentations on pharmacology, pharmacy revision, OTC medications, OTC conditions, and the legal aspects of prescribing, please follow us on our Facebook, Instagram, and YouTube channel.